Welcome, everyone. Bonjour. It's really great to see so many of you here today online with us for the first of 3 events in our Delivering Equity in All Child Healthcare Services pop-up series. Before we get started, I wanted to acknowledge today that I'm joining the event from the traditional and unceded territory of the Algonquin Anishinaabe peoples. This territory, in case you weren't familiar, spans both sides of the Ottawa River and includes what we know today as Ottawa and Gatineau. Beyond its natural beauty, the Ottawa River was critical to the Algonquins and their fur trade, and it was also the site of the timber boom that was central to their economy. The river then, and even today, is an important part of our ecosystem that supports plants and animal life that sustained the Algonquins. We're honored to call this land home. Please take a moment to introduce yourself in the chat, and maybe you can share where you're joining from today as well. We are thrilled to be hosting this event, delivering just-in-time learning on issues and priorities that have been elevated by our members with a focus on improving health systems that care for children, youth, and their families. With 300 child health leaders registered today and an additional 400 signed up for the second and third parts of the series, it's clear that improving health equity for children and youth in Canada is a priority for us all. As many of you know, Children's Healthcare Canada is on a mission to right-size healthcare systems serving kids. Through our consultations with youth, family partners, healthcare providers, researchers, and so many others, we heard very clearly that collectively we have a lot of work ahead of us on several fronts, but especially related to how we improve health equity for children in this country. Our role as a national association advocating for kids and the healthcare systems that serve them is to convene our members and to facilitate shared learning and support each of you to deliver safe, effective, and culturally appropriate care for all kids living in Canada. It's also our role to elevate opportunities to improve health systems to better meet the needs of a growing population of kids who identify as Black, Indigenous, or otherwise as persons of color, who have disabilities or neurodiversity, who live in rural, remote, or northern communities, who experience poverty, or who are navigating their gender identity and experiencing worse health outcomes than the average. As each of you would acknowledge, racism, colonialism, white supremacy, trans and homophobia, ableism, and all sorts of other forms of discrimination are present throughout our healthcare systems in Canada, including those that serve children and their families. Children's Healthcare Canada believes that no child should be held back by systemic disadvantages or barriers, which is why we're committed to implementing the principles and practices of equity, diversity, and inclusion into all aspects of our work. This includes our advocacy and includes programs like our webinars, podcasts, our networks, and events like these. I mentioned earlier today that this is the first in a series of 3 discussions focused on child health equity. Coming up later this month on March the 21st, our conversation will focus on inclusive child health research for equitable outcomes. And on March 28th, we'll dive into evidence-informed policy to advance health equity for all children. Our goal over these 3 sessions is to convene our community, to connect child health leaders across the continuum of care, to discuss core principles of child health equity and how to embed them in organizations like yours, how to share evidence from research, practice, policy, and lived experience and resources to informed shared decision-making at the practice, research, and health system levels. We're also hoping to identify and explore effective and equitable models of healthcare, child health policy, and research, and to identify opportunities for collaboration and alignment. Ultimately, our goal is to improve service and health outcomes for children and families from underserved communities. Let me take a quick moment to thank our sponsors, without whom we couldn't be here today, the IWK Health Centre in Halifax, Nova Scotia, and One Child, Every Child, which is a CFREF-funded research initiative out of the University of Calgary. Thank you so much. It is now my honor to introduce our opening keynote speaker, Dr. Nicole Catherine. Dr. Catherine is an assistant professor and associate director of Children's Health Policy Centre in the Faculty of Health Sciences at Simon Fraser University in beautiful Vancouver, British Columbia. Dr. Catherine also holds the Canada Research Chair in Child Health Equity and Policy. She conducts research on the early prevention of child health inequities and on ensuring inclusion of underserved children in both research and policy. Nicole's research is informed by policy and practice priorities as embedded within reciprocal policy and practice relationships, also ensuring that results are used to improve conditions that serve and services for children and youth. Over to you, Dr. Catherine.
Thank you, Emily. Hello, everyone. Let me just share my screen. It's a pleasure to present today on child health equity, ensuring that all children thrive. I'm calling in from the traditional and unceded territories of the Squamish, Tsleil-Waututh and Musqueam nations and other Coast Salish peoples on lands that are now called Vancouver. I identify as a biracial woman, and I come to this work having experienced privilege in circumstances, including access to higher education. I was born in rural Scotland, being raised by my strong single mother. I also experienced racial harassment throughout my childhood, and I emigrated to Canada in my early 20s. And so my life experiences are reflected in my pursuit of child health equity. Today, I'm going to talk just a little bit about child health equity and then provide some research policy exemplars, including the BC Healthy Connections project and a project called the Elizabeth Fry Voices. Child health equity is when all children have fair opportunity to thrive, to be healthy, and to receive quality care. It is also the absence of unfair and unjust avoidable differences in health among groups or areas. And we know that up to 80% of variation in health outcomes are due to social determinants of health, and that children in particular are sensitive to social determinants of health. Unavoidable childhood adversities contribute to lifelong health problems, and some of these potent threats are family socioeconomic disadvantage, racism and colonialism, and child maltreatment. And we know that social disadvantage can cause family stress and difficulties, which can increase the risk for child maltreatment and therefore lifelong mental health problems, which leads back to social disadvantage. And so the cycle continues. So my child health equity research work is focused on early prevention, starting as early as we can to support families and children experiencing disadvantage. So one exemplar is the British Columbia Healthy Connections project. And this is where we evaluated the Nurse Family Partnership Programme. It aims to support young first-time mothers coping with disadvantage to prevent childhood adversities. And it's a nurse home visiting programme involving up to 64 public health nurse visits over 2.5 years through pregnancy and right through till children are age 2. And so we had known before this project that there was evidence from 3 randomized controlled trials of nurse family partnership in the United States with very long follow-up over 20 years. And it had shown many benefits across different domains like child maltreatment, mental health, both for parents and children, parenting, and even decreased child and maternal mortality by age 20 years, and saves $2 to $6 for every dollar spent. But we didn't know how NFP worked in Canada, and so we needed to rigorously evaluate it before widespread implementation, because outcomes may differ across contexts between the United States and Canada, especially because of our difference in existing health and social services. So we led the evaluation here at the Children's Health Policy Centre at Simon Fraser University, along with McMaster and other universities. And it was supported by reciprocal and sustained research policy practice collaborations for the full 11 years and are still ongoing now. And so here's just a schema of our very engaged and active research policy practice collaborations. We collaborated very closely with the BC Ministries of Health, Children and Family Development, and Mental Health and Addictions, as well as the BC First Nations Health Authority, Métis Nation BC, who sat on our Provincial Advisory Committee. We also worked very closely with 4 regional health authorities, Vancouver Coastal, Fraser Island and Interior, who delivered NFP throughout the trial, and Northern Health were also involved. And then we had a national scientific team. And so it was this collaboration that allowed us to develop eligibility criteria for the trial that ensured ease of screening by the public health nurses. They were the ones that the trial was embedded in public health. The nurses were screening pregnant girls and young women for prenatal services, and then would see whether they would potentially be eligible for this project in this trial. And having this collaboration ensured that we would reach and include equity-deserving families who could benefit the most from nurse-family partnership, typically those experiencing the most disadvantage. And this was the eligibility criteria that we collectively came up with. Some of it was to meet the nurse-family partnership criteria, which is that they must be young, preparing to parent for the first time, as early in pregnancy as possible, but no later than 28 weeks. For the BC trial, they had to be able to provide informed consent in English, and they had to be experiencing socioeconomic disadvantage, which we operationalized as either being preparing to parent as an adolescent or being aged 20 to 24 and experiencing limited income, limited access to education, or preparing to parent while single. And we identified some main outcome indicators across the domains of pregnancy, child health, maternal health, with childhood injuries at age 2 being our primary outcome. And then we looked at prenatal substance exposure, child development, and subsequent pregnancies, which I'll come back to. And this is just a schema of what the trial looked like. We recruited the mums when they were in pregnancy, and then they were randomly assigned to nurse family partnerships and the existing services on offer in BC, or the comparison group, which is just the existing services offered in BC. And then our research team drove around the 4 regional health authorities for 6 years and did telephone interviews and interviewed all of the participants across 6 time points. So pregnancy, and then 2, 10, 18, and 24 months of age, so that we could then look at the data in both groups and then compare the outcomes at the end of the trial. And NFP is delivered through pregnancy, also right up until age 2 years. And we had some success. We managed to reach and include 739 new and expectant mothers and their 731 children. We were then able to sustain their inclusion for over 2.5 years of their participation. We collected data from 3,700 research interviews, many of them in person, driving around many of the regional health authorities. We found some positive program benefits prenatally by age 2 years. And from the scientific team's perspective, this warrants follow-up across childhood and adolescence. And so throughout this whole project, the project itself was informed by policymakers and practitioners. It was embedded in public health, with nurse-family partnership being delivered by the nurses. And then the findings, as they were coming out and being published, were quickly shared back with policymakers and practitioners as well. So very much a model of integrated knowledge translation. And throughout it all, we honoured our participants. They told us that through this study, they felt that their voices were being heard, often for the first time. And so I'm just going to touch on a few of the main findings from this trial. The first being maternal disadvantage. So we really wanted to look at the baseline data after the girls and young women had been enrolled, but before they'd been randomly assigned to comparison or NFP. Our wonderful research interviewers went to their homes and sat with them and asked them questions about their lives, their experiences, their characteristics. And then we wanted to look at that data to see, did we even manage to recruit and find and include a group of young expectant mums who are experiencing disadvantage, because our eligibility criteria were quite non-invasive. So, education, income, and being single. And so we had to look at the baseline data again. And also, one of the other reasons we wanted to look at it is that when we were developing the trial with our senior policymakers and practitioners, many were saying, we just don't think there's that level of disadvantage here in BC. Like, many of them have access to higher education. I'm not sure if we'll be able to find the population experiencing disadvantage. So we had to look at the baseline data. And we looked at our eligibility criteria, and we could see that we did indeed have reached half of our sample were adolescent and preparing to parent. 84% did have low income. Half of them had limited access to education, and the majority were preparing to parent alone. So then we looked at the rest of the data, and sure enough, we could see many other associated adversities. These mums reported unstable housing, mental health issues like psychological distress, anxiety, depression, or prenatal substance exposure, as well as physical health challenges, and then even experiences of maltreatment, either in their own childhood or recent intimate partner violence. And when we looked at the cumulative disadvantage, we found that the majority of our sample reported 3 or more indicators of disadvantage, and more than a third reported 6 or more indicators of disadvantage, and this is then preparing to parent for the first time. So what this means is that we found that pockets of extreme socioeconomic disadvantage do exist in BC for young first-time parents, and that these data also tell a story of strength and resilience. These young expectant teenagers and mums came into contact with prenatal registries and agreed to be part of a research study for 2.5 years involving their first child. And yet more needs to be done to address social determinants of health. We need to be providing a living income and ensuring access to education and housing. Another finding that we looked at was reaching underserved children and families. So we know that researchers, policymakers, practitioners often fail to identify and address barriers to inclusion, and they unfairly label children and families as hard to reach. And so we used the BC Healthy Connections project as a case exemplar for developing a planned, theory-informed retention protocol. And there were 6 steps to this: reviewing the literature, developing a theoretical ecological model, then developing a framework, looking at barriers, strategies, collecting data, and then having recommendations to guide health researchers and also policymakers. And so this is our ecological model, just showing the different layers and contexts for participant retention or inclusion. And then we looked at retention over 3 study phases: planning, engagement, and maintenance. And then this is a schema of what we did. We really invested a lot of time and resources training our field interviewers and our staff about the importance of retention and supporting them for tuna. There was actually 6 years worth of data collection, and really supporting them in creating rapport with the participants, finding ways to stay in contact, to find them as they moved around the province, sometimes many of them experiencing unstable housing, or because of limited income, their cell phone, they wouldn't have minutes or data for their cell phone, so their phones wouldn't work. And then we also captured a lot of data on the number of attempts, whether they were successful, the mode of the attempt, whether it was text or email. And then we monitored our interview completion rates for the research interviews to see what it took to stay in touch and to engage with these families. And we had some success. So I've highlighted that we conducted 3,700 interviews, and they're in prenatal at 34 to 36 weeks pregnancy. That's one of our main outcomes. We had 90% inclusion or retention. And then by the end of 2.5 years, when children were aged 2, we had 83% retention, which is you need at least 80% in a large trial to be sure of rigor. And we had very high retention for our administrative data linkage on our primary outcome. And when we asked, at the end of each interview, we wanted to hear from the young girls and mums in their voices, why did you participate? We have a little book of all their quotes because it just was so rewarding. And one of them, for example, was a common sentiment was that I appreciate that they, the researchers, never gave up in having me involved. And so we've published this report. We're hoping that it helps inform retention in programs and services, helping to reach all children to reduce disparities. And we hope that this research may shift policymakers and practitioners' perspectives from hard to reach to need to reach. And in fact, we use that term in our research study, in our daily language. We call them, this is our need to reach population. There's a certain population that had more barriers, and we really had a lot of barriers trying to stay in touch with them. And we called them our need to reach population. And we invested a lot more time because they're the ones that were typically experiencing the most disadvantage and are typically invisible or excluded from programs and services. A third finding from our trial is that we found reductions in prenatal substance exposure. We know that families that are exposed to socioeconomic disadvantage, that are made vulnerable to structural and systemic barriers, have an increased risk of substance exposure, and that this can have lifelong mental health impacts and developmental problems for children. And so what we found is that nurse-family partnership resulted in modest but significant decreases in cigarette exposure. This was the mums reporting on this. And this is important because any reductions may benefit the developing fetus, because we know that low levels of cigarette and nicotine are harmful. And we also found that NFP resulted in significant decreases in cannabis exposure, again, maternal report. And we know that cannabis exposure adversely impacts fetus and child cognitive and behavioral development. We know that harm reduction efforts need to be intensified. 25% of our girls and young women were reporting prenatal cannabis use. And NFP therefore might have a role in these efforts, especially for this equity-deserving population. We also found improved child well-being. So at the very end, at the 24 months, our research team met with the mums and met with the toddlers at that time, and mums reported improved child language, so greater vocabulary for the NFP mums and children, and decreased problem behaviour or mental health problems by age 2 years. What we didn't find, though, a big limitation, is that we didn't see any benefits on our primary outcome of childhood injuries. And also these findings that we have seen on prenatal substance use and language and mental health are limited to maternal self-report, which are subject to bias. But it was a rigorous RCT design. We had very strong retention, and the scientific team warrants that follow-up across childhood and adolescence. So that's something that we're pursuing now, as the children are about to turn around age 10. And so what these findings do emphasize is that prevention needs to start before age 2 years, before problems are already established or become entrenched. We know that problems as early as age 2 are predictive of later problems, and that these are associated with greater service utilization and high costs to society. And so NFP today continues to be delivered in select health authorities, and we've secured new funding to investigate ongoing adaptations to make sure that we can meet the needs of BC's diverse families. And so throughout this whole trial and all of the results and papers that we've been doing, we've consistently had integrated knowledge translation, ensuring active and reciprocal engagement throughout the research process, through academic publications, policy reports, talks and media, and ensuring that we share these results provincially and nationally, and also with global NFP efforts. And then the second project I just want to talk about is something called our Elizabeth Fry Voices project. And this actually stemmed from the BC Healthy Connections, in that we really wanted to know from the mums, because we used a lot of survey data in our research study, but we didn't have the opportunity to do qualitative data and actually have some stories and listen to the mums and hear from them in their own words about their experiences. And so we really wanted to know what were some of these mums' experiences of being offered a program, and what would be some perceived barriers or facilitators. Do they even want a home visiting program? Like, let's slow down a bit and just see, like, if you were offered one, what would be some potential barriers or facilitators? So we were very fortunate to connect with Elizabeth Fry. So here, children and families with greatest needs face barriers, and they are traditionally excluded or invisible from health research, and therefore excluded and invisible from policies and programs that can help them. And research inclusion is vital in giving voice to equity-deserving populations. So we partnered with Elizabeth Fry Society of Greater Vancouver. I think there's about 11 chapters across Canada. The Elizabeth Fry in Greater Vancouver serves girls and women experiencing disadvantage, so poverty, homelessness, mental health problems, including substance use or recent incarceration. Elizabeth Fry offers recovery programs or temporary shelter homes, parenting and counselling. And so we conducted some community-based participatory research. We asked mums about their perceived barriers and facilitators. So we collected some survey data from them, 38. But then of those 38, they were all invited to participate in an interview to ask them a little bit more. So 20 agreed to talk to us through an interview. And we had three main themes about accessing programs, and some of these programs were beyond Elizabeth Fry. One of the main themes was the need to understand and improve access limitations. One woman said funding is a big thing, also childcare. Mums can't do much if they don't have childcare. Another theme was providing safe and safer services. One mum quoted, having extra support and being able to be honest with the doctors and stuff made recovery more manageable, because a lot of places are really judgmental. And so when you're being judged, it makes me not really want to receive those services. And a third theme that came through this research was orienting programs towards whole health. One mum was really fantastic in her sharing, and that she's saying, I want to go back to school. I have goals, right? The problem is I also need affordable housing so I can feed my child. And so with this research, we're centering mothers' experiences, we're co-creating and deepening shared knowledge, and we're hoping that this will inform equity in the provision of services and programs, and hopefully redressing the invisibility of BC families experiencing marginalisation and criminalisation. And so in conclusion, I just want to say that this work collectively is generating new knowledge on the effectiveness of early interventions and barriers to equitable provision of services for children. And it really requires sustained, active research policy collaboration so that we can directly inform those who can act, as well as always honouring children's rights. All children have rights to safety and nurturing, opportunities to flourish, access to needed services, and all children are a shared collective ethical responsibility. I just want to thank our participants, our team, our funders, leave you with this message that children are the living messages we send to a time we will not see. So thank you for keeping the focus on children. I'm happy to answer some questions.
Thank you, Catherine, for a great presentation. I'm going to give the folks in the room a chance to get some of their questions typed in. And some takeaways for me are you've clearly conducted an integrated knowledge translation research project, which is just beautiful to the knowledge mobilization person in me. And you're sharing the importance. I love hard to reach and need to reach. I loved the impacts that you had. Interesting that it did not reduce injuries in children. Do you have any insights as to why that might have been or what you might do differently?
Thank you for that feedback, Paula. For injuries, we did find a small, I think what we might have needed was a much larger sample size and more powered. So we found a small exploratory finding looking at hospital length of stay. And what we found was that NFP appeared to reduce the numbers of days hospitalized for severe injury. And that's actually a really robust outcome, is looking at days hospitalized. It's less bias. It's such a sad thing to talk about, but it's less bias. So in a sense, there's a surveillance effect that has been shown in some trials for NFP, where mothers who receive NFP and have the support of this phenomenal public health nurse and this therapeutic relationship for 2.5 years, they are more likely to go receive help for minor injuries because they're feeling actionable and they want to seek support for their child. And so you might see a slight uptick in receipt of community outpatient doctor's visits, and maybe mostly that. So really you want to be looking at hospitalizations or emergency room visits for more severe injuries. And we actually did see a trend towards that. But because I feel like we just needed more. What we can do is we can be gathering that data on a large population across the province over many years to see if it really does shift that dial towards decreasing hospitalizations for severe injury.
There were several folks in the chat box commenting on similarities between, for example, your project and the Healthy Babies, Healthy Children project or service in Ontario. Have you compared or contrasted your initiative from theirs?
No, I haven't actually. No. Happy to answer specific questions about it, but we haven't done a compare and contrast yet.
Type away, folks, in the question and answer box. Your retention protocol. What were some of the lessons for policymakers and practitioners, as well as researchers, of course, but drawing from your report, reaching underserved children and families?
Yeah, so we found that really having that robust engagement protocol helped families to participate in those 6 interviews over 2.5 years. And so the participants taught us that we needed to make frequent contacts. So sometimes about 6 phone calls, sometimes up to 10 or 11 or more. And we know that that's important because in BC, for example, if you've just had a baby, you will receive one, if you're low risk anyway, you'll receive 1 phone call. And also, I think after a few attempts, public health nurses are busy. They're going to have to move on and try and reach the next mums who've just had their babies. And so what we were finding is that those mums experiencing the most disadvantage, you can't give up after 3 phone calls. Or if you have someone on your caseload as an NFP nurse and they're not answering their phone and they haven't for a while, it just needs that ongoing sustained engagement to really ensure that invested resource to ensure that they are included. We also found that we definitely needed more outreach for those families experiencing more adversities. We had the need to reach sort of subpopulation, the ones that we really were facing a lot of chaos in their lives. And participants told us that many of them said, thank you for persevering so that we can stay included. The whole way through, the mums were always saying that their main reason for being in the study and for participating for so long is that they wanted their voices to be heard. They wanted to change the services for future girls and young women like them, and they want to see a better future for their children. So really, they want to be involved and they want to be included. And so we also found that texting was the most effective approach, which probably is not a surprise. We really needed to invest in training for our team, and this all paid off. And we know that all of these strategies might pose challenges for policymakers, like initial costs for resources and training could be high, and offering evening and weekend appointments were really important, and that could be difficult, but we know that the benefits would be substantial.
Pardon me, time and location and access to transportation have always been huge issues for similar programs. So those are certainly policy directions that folks can advocate for. In terms of home visiting, the question that has come in, do you feel the home visits are crucial, or can virtual care suffice?
Ever since the pandemic, there's just been a huge focus on delivering programs virtually and through, say, telehealth. And I think there's definitely a need for it in communities that are more rural and remote. We know our trial was in more suburban and urban centres, and it really is. I think it's really beneficial to be delivering this program in any way possible rather than not at all. And that if telehealth is the way to do it, and virtual, especially for populations where you just can't drive to go see them. And of course, being in person, there is a lot of benefit of seeing your nurse and having them there and seeing them in the room with you. But as you know, not having any connection is worse. So we know that there's 1 or 2 sites in interior health, and some researchers there leading an evaluation of delivering NFP through telehealth. And so it's very important to explore those modalities, and also ensuring making sure that we don't have digital exclusion, because it's also difficult sometimes to have a computer and data and a Wi-Fi and a signal as well. So how to overcome barriers to digital exclusion if you are developing telehealth or virtual interventions. But definitely a huge promise there.
Fair. There's a question around, did you collect data from nurses about what it took to access and provide this care in the need to reach group? And our system is so often gives up, as you said. Did their feedback help inform new directions or new ways of doing?
So there was a wonderful process evaluation of delivering NFP conducted by Dr. Susan Jack from McMaster. And so she interviewed all of the NFP nurses across BC and asked them about many different ways of delivering NFP in BC. But one of the things I would love to be able to do is exactly that, is ask them about this sustaining inclusion and what's needed for NFP nurses to have the time and resources to do the work that it took for our research team. It takes time. I mean, there was doing the job and collecting the data, but then there was the sitting and trying to find them, and it took time, but it's so important. Mm-hmm. And so I would love to do that. I would feel like that's one of the next steps that we're looking at, is to talk to the mums and the nurses about that piece of, why do they even decline having a nurse in the first place? Or why did they drop out in the first place? And I'd love to also ask nurses, what made it difficult for you to stay in contact? What do you need? What resources do you need to spend that time? And I was even thinking, gosh, do we need like a student that sits with the nurses and dials all the mums? And because that's what it took, is like, because the mums weren't answering their phone. And so that's definitely a really important avenue for the future. And I would love to do that work.
Brilliant. You have a long to-do list, it seems. Another question, the poster said, I may have missed it, but was the data stratified by race or other equity factors?
Another great point about BC's diversity. So because of the power needed for the analyses, we put everyone together. And so this is one of my great learnings from doing an 11-year randomized controlled trial with my fabulous colleagues, is that there are great strengths of a randomized controlled trial, but it's in a homogenous group. They're treated homogenously. And we kind of needed it to look at, you get to do causal comparisons and there's power there. But what we learned, what I've been learning through that experience, was that we were missing for who and for what, under what circumstances. And that's where some of this new funding I'm seeking is to really explore, how do these programs fit for specific equity deserving populations that fits with BC or Canada's diversity, newcomers, older mothers. So NFP, you had to be fluent in English to receive the program and participate in the research interviews. But that is not BC at all. And you had to be a first-time mum, but we have multiparous mums who are experiencing disadvantage. So our next step is really to start engaging in more community-based participatory research, looking at what works for specific populations, and again, under what conditions and where. There's a new term called precision home visiting, that's what they're calling it, but there's some real strength to that, because we're honing in and we're looking to see what works in house, so that we can fine tune and be a lot more respectful and inclusive.
Have you considered any I don't know if it's return on investment or cost analysis around, so one could advocate with governments about the cost of doing this well?
Absolutely. So we know from work done in the United States that being able to show like the $2 to $6 saved for every dollar invested, that's really important. Like, we need to know, are we making a difference and are we saving funds? I mean, it's all crucial stuff. And so that's our long-term goal, because really you start to see the savings across multiple sectors when the children are by late adolescence. Did they need extra help and extra education? Were they involved in the criminal justice system? Did they engage in employment? And what about their health? So we collected through the trial prenatally to age 2 all of the, it was a huge aspect of our survey. It was called the Service Access and Use Forum. And we asked them, what did you, every interview, what service did you access? And we did we knew in each health authority what services were on offer. And we asked them how often, we asked them about their barriers. And so we're going to do that again at this follow-up when children are age 10, and then we'll do it again in late adolescence. And at some point when we see that we will pull that all together and do an economic analysis. But we didn't think it would be worth it by age 2, because you just might not see that differences as profound as you will see across the developmental domain. So we have the data and it's our plan.
And that is the challenge with health promotion, prevention, protection, in terms of the length of time it takes to see meaningful results, and a policymaker cycle in terms of government funding. That seems to be the end of our time. Thank you so much, Catherine. This has been an incredibly important discussion, and just the start of many conversations we're going to have. There's lots of interest in your publications. We'll be developing a report coming out of the 3-part series, and I'll loop back with you, Catherine, to get some links to those that we can put in that report. Thank you so much for your time.
Thank you so much, Paula. Thanks, everyone.
Take care.